Got it. Okay, I'm muting myself.
Jess, that's awesome.
Thank you. We'll talk more about transition plans, because obviously you're one of our big contributors.
Excellent. Well, I am
going back to Texas where they belong, actually. So
Diggity dang right.
yeah.
There are a lot of Southern accents on the call today, for sure.
Yes, there are.
Okay, well, I can talk about our case that is still in the present tense. Luckily, this is an 8-year-old male neutered corgi, and about a year ago had routine blood work performed that showed evidence of chronic kidney disease. Back in July of 2021, had a creatinine of 2.3, an SDMA of 27, and the urine was dilute at 1012. A UPC at that time was 2.1. So the patients have been, this dog was just managed with diet and just traditional therapy, maximizing I forget if it was on an ACE inhibitor, or I think it was on an ACE inhibitor, and then eventually switched over to an ARB. And things have been fairly stable. Creatinine range between 2 to 3. UPC stayed anywhere from 0.8 at its lowest point up to 3.6 in March, and then went down to about 1.4. So kind of the fluctuations we'd expect with daily variability in proteinuria, but no obvious trend in progression or improvement. There was also one isolated time where the dog was diagnosed to be hypertensive, but the dog was quite stressed at that visit. Otherwise, it's been at the upper limit of normal. Our last blood pressure was 150. So this dog was biopsied because of its chronic history. Owners were very interested to find out what might be underlying and if there was any ability to manage this dog. Also did have some mild hypoalbuminemia, which made us a bit more worried that maybe this was a glomerular disease driven component, and the albumin was about 2.2 and had been that way for most of 2022. Even going back to a year ago when it was first diagnosed, the albumin was only 2.4 at that time. So the dog has had low normal or mild hypoalbuminemia throughout this time as well. So we biopsied the dog to try to get a better handle on what might be going on, to the reason for it to have chronic proteinuric kidney disease. I don't know if that works for you, Rachel, to take over and start showing some of the slides.
I wonder
Yeah,
if
I am just running. Let's see, I need to get my stuff ready. Okay, so I need to make sure I'm sharing the right screen. Okay, so this particular
So as Rachel is getting things set up, I'll just kill some time so we don't have dead air. So this case, I discussed it with some human nephrologists, and some of them were quite shocked at the specific gravity in dogs ranging up to 1030 and 1040, and generate some discussion of, are dogs chronically dehydrated? Is that why they have specific gravity of 1045? And their minds were blown when I told them that cats could routinely be in 1050s and 1060s. And I was just amazed that talking to these very, very knowledgeable nephrologists, when it came to translational medicine, they had no idea about anything. You know, you would tell them like, oh, this is the normal creatinine of a dog, and they were surprised at their various reference ranges and whatnot. So there's lots of interesting facets about this, where in discussing with human nephrologists, it was a bi-directional educational opportunity.
yeah, they are often unaware of what we do. Although they like to promote that, hey, we've got a veterinary nephrologist here, especially at OSU. They're like, we've got one, and then they or nepropathologist, I guess I should say, and then they forget all the stuff I've taught them. But so I just want to compare. Hopefully, everybody is seeing a biopsy core that had. This is the PAS, which is a lot of the pictures I was showing you before with the counting cellularity, so. Now in comparison to the previous case, which had cells everywhere, right? Like all of the capillary lumens had cells. There was tons of cells in the mesangium. This is a little bit different. We have more prominent mesangial hypercellularity. So here we have a little supporting rim of mesangium, and we have 7 nuclei in that region. So too many. And there are a few capillaries that have too many cells too, because the endothelial cells count in your endocapillary hypercellularity. So we have this capillary loop that has 3, we have this capillary loop that has 3. So it's not nearly as hypercellular as the last case. This one also is actually a little bit more classic for this type of lesion because we have a lot of PAS positive material. Oftentimes this is considered to be hyalinosis, and hyalinosis is plasma that is being pushed into areas it shouldn't be pushed. So we often say the word insedation. And so this one has that kind of PAS positive material. And the other thing is that in this particular case, it might not be hyalinosis. It might actually be our deposits that we're going to be looking at soon. And then we also have areas where there are glomerular capillaries that are just lost. Like we don't have that glomerular capillary anymore. And we have an adhesion between the tuft and Bowman's capsule. Overall, there is tubulointerstitial injury as well, and we have some inflammation. Oftentimes, the inflammation kind of tracks around the glomerulus, and then we had some globally scarred glomeruli as well. I'm just going to hop to the Jones to show you the remodeling in just a moment. And I forgot that this is the Jones that didn't stain very well. This is a very hard stain to do adequately all the time. So I'm just going to put that out there. We at OSU do it by hand. Zoetis does it on a machine, and Zoetis's auto stainer for the Jones was phenomenal. I don't think I've ever seen it as repetitively as good as it was. And so I don't know, it might be something when we move to Texas A&M, we might try to put it back on the auto stainer because theirs was really great. But basically what I wanted to show you was the fact that there's kind of a little bit of that same double contribution of the capillary lumens, but it's not really poking out very well because of the fact that it's not great stain. Okay, so I was able to say like, hey, JD, I don't know, it could be this, it could be that, it could be just bad podocytes. And so you have some sclerosis because the podocytes are inherently bad. It could be that there's some deposits. If there are deposits, I'm not sure really where they're going to be located. We're going to need all of the additional studies. And so that's where things get cool. So I'm going to stop sharing this. I'm going to go back to that. Oh, I don't really want to. Oh, I need to see, let me go do one thing really quick. Okay, so we're back to the original report. I just want to make sure that I have the other report up. Okay, hopefully now you're seeing Kobe's information. Correct? Yeah. Okay, so so I was just kind of scoping along, and you guys can see these electron micrographs, and there's some electron densities, and that's usually what I'm looking for to see what, if I have immune complexes, they're going to be little densities. And then I'm going to say, are they in the base membrane, or are they on the outside surface and the inside surface? We also have right here, if you can see this kind of outlined structure that has a regularity to it, that's a mesangial cell that is growing its little tendrils of cytoplasm into the capillary wall. And so the term for that is mesangial interpositioning. And so usually that means there's been some kind of damage. Maybe there's immune complexes, maybe there's structural damage. And so the mesangial cell is kind of extending its tendrils out to support the capillary wall. And so I can already say, like, okay, there was something going on with this glomerulus because we have some mesangial cell interpositioning. We have this little bleb here that's quite homogeneous and pretty well demarcated from the capillary wall right here. And so at first I thought, okay, well, that's probably just that hyalinosis, that PAS positive stuff, which, excuse me, I know I'm going to make you guys vomit, but that PAS positive stuff that was kind of at some of the glomerular capillary lumens where it was that bleb of PAS positive material like this bleb of material. Oh, I guess that's just hyalinosis, because that's usually what hyalinosis looks like at that magnification. But then you go closer and then you see that you have these substructure to this bleb. So go back up to here. Here is our bleb that I at kind of eagle eye view thought was hyaline. Go closer and I start to see that there's fibrillar components to this material. And also you can see, if you're even closer, these are almost a microtubular appearance. So you have these parallel walls, and that's the limit, I guess the outer part of that cylinder. But then you can also see right down here, let me get these you can see that there's actually circles. So these microtubular structures are coming out of the screen towards my face. Or going into the screen, whichever one, but I can see that ring, which is the structure of that microtubular component. And so usually we try to measure those. And so here I'm measuring one of the diameters of those rings. And they're around 30 to 40 nanometers in diameter. So that is way too large to be amyloid. And also amyloid doesn't have this kind of linear tracking structure. There are much smaller fibrils. So it was like, well, that was weird. I don't know if I'll see more of that. And then as I went further along this case, all of those little electron dense regions that were kind of smudgy little deposits ended up being microtubular appearance. So in human medicine, we have a name for this, which is, well, we have multiple different categories, but if you're thinking about how you do your decision tree for diagnosis, you would have like immune complex deposits, and they're going to have immunoglobulins, they're going to have antigen. They usually are also going to have the ability to activate complement. So they're going to have intermixed complement proteins, and that's going to be on one side of the cascade of your decision tree. You have other types of things that fit in there, which are also pretty uncommon in humans and rare in animals and our pets. I've seen like one or two of each of those kinds of weird things. But on this side of the decision tree, you can have deposits. They are deposits in the glomerulus, but they are not made of immune complexes. Let me just say this: they are not true immune complex mediated disease. And we subdivide them because they have a fibrillary structure. So one of the fibrillary structures of that cohort would be amyloid, because it's a fibril. And then another one would be these deposits that are much larger than amyloid. And so there are a couple of those. There's one that's just fibrillary GN, fibrillary glomerulonephritis. And then the other one is called immunotactoid GN. And I honestly have never looked into the etiology of why we say immunotactoid. Immunotactoid has a microtubular appearance, and they're like the largest of all the organized deposits. Now, I'm not saying this is immunotactoid. I'm saying it's immunotactoid-like. And those kind of fibrillary immunotactoid type diseases often have components of immunoglobulins in them. Like they will have immunoglobulins as part of the fibril. but they are not deposits with antibody antigens stuck inside the glomerular base membrane activating complement. So that entire inflammatory cascade isn't really happening. It's just that they are parts of immunoglobulins that form fibrils. We actually know, in contrast, when you think about amyloid, in amyloid for animals, it's, you know, serum amyloid A that's going to be making the fibril. Occasionally, you can have other proteins in animals that make amyloid fibrils. In horses, they can have fragments of their lambda light chain that can make a light chain amyloid. Plasma cell tumors can technically make a light chain amyloid. And in human GN or human glomerular disease, most of their amyloids are made of light chain fragments. So a lot of things get overlapped because it's annoying because it's still an immune particle. It's still a molecule that is part of the immune system, but it isn't the true immune complex disease where you have an antigen that is stimulating overproduction of the antibody. They are binding and they are getting deposited, because in that type of disease, you actually have two things you can kind of try to attack to cure the disease. You can try to get rid of the antigen itself, and you can kind of quiet down the immune system. In this type of disease, if it's true immunotactoid and true fibrillary, and they are bad parts of immunoglobulins, they still have immunoglobulin components, but they're not responding to an antigen. They're just being overproduced. Oftentimes there's, well, I shouldn't say oftentimes, they occasionally are associated with bone marrow dyscrasias. So they might have a plasma cell clone somewhere, maybe in their marrow, somewhere else, that is making bad immunoglobulin components. And so those immunoglobulin components are not normal, and they are predisposed to forming fibrils or microtubules. This particular case had kind of a linear staining, and then you can see, so we're doing IgG here for fluorescence. And so when I'm looking at immune complex GN, I really want to see ... and each one of those dots is an immune complex. And in this particular case, occasionally you might see a couple of granules, but mostly you're just seeing this kind of like splotchy, hazy staining. So whether or not it's just because these things here are components of IgG, it's possible. And that's why we're getting the smudgy staining versus a true ... that would be indicative of immune complex disease. Here, lambda, again, we have much more splotchy stuff. And so again, this might be because there's portions of these microtubular components that are able to light up with the lambda light chain IF. So that was a gee whiz from our perspective. When I texted JD to say, hey, you have deposits and they're weird, it looks like immunotactoid disease, I went back to our database and I was looking for other cases that had organized deposits. And I said, oh, wow, I forgot that Dr. Shropshire had sent us this consult case that had organized deposits as well. So now we're back to that first case, that pregnant dog that ended up being euthanized, that really hypercellular glomerulus. You can hopefully see, and I'm really hoping I pulled up the right one to make sure. It's Cheyenne, correct? Shropshire?
Yes. Yep.
Yeah.
Cheyenne.
I was like, you had 3 in a row, and I was like, maybe I opened up the wrong one. So we have a really hypercellular glomerulus. We start to see these deposits, right? These electron dense deposits. And at this mag, even I'm kind of like, well, they don't look that normal. They look like they're abnormal deposits. So we go higher mag because that's what we do in electron microscopy. I'm assuming the picture will be here soon. And you can, I didn't mean to that. Here they are. So these guys are, you can see this little microtubular structure here, and a microtubular structure here, and one there, and one there. And so her deposits were actually kind of a combo. Oh, here they are. They're really good. You can see them here. You have the microtubular component, and you can have, so here's it. Here the crosshairs is going up one tubule. This is going down another tubule. Here's a tubule here. They're a lot of the deposits had the microtubular substructure, but there were deposits that were just kind of run-of-the-mill deposits as well. So again, not sure why these 2 different dogs with 2 different types of histories had these organized deposits. But I think JD, when we looked back in the database, I think I've only had like 5 or 6 of these cases. Is that correct? I think I sent you the list.
I think it was maybe 3 or 4. Yeah,
Okay.
very, very few. And I
Okay.
think not a lot that actually, I don't think we have any that are alive except for our patient.
Yeah, I did know that. Like 2 of them we had identified after autopsy. And then one of them I think was a cat or something. Yeah, so so JD, do you want to give us a little more information about what the MDs were talking about when it comes to this kind of organized fibrillary disease?
Sure. So if we make the presumption that this most closely resembles immunotactoid glomerulonephritis in people, it is still a fairly rare disease that's observed in people. In about half of cases, as Rachel had mentioned, it is associated with some type of monoclonal gammopathy, and that's often due to a chronic leukemia that might be in the bone marrow. It could be, it doesn't have to just be in the bone marrow, it could be systemic. This also can fall into what's called a monoclonal gammopathy of renal significance. MGRS is what they abbreviate that, and that's where secondary to this paraproteinemia, you have deposits that are occurring that is not completely worked out whether they are getting filtered and trapped or the endogenous B cell population of the kidney is upregulated and laying down these proteins. And it's thought maybe it's more so the latter. So the thought is, well, what do we do now? Do we immunosuppress this patient? Because that is what is often done if people are given, the people who don't have cancer, obviously those who have cancer are treated with chemotherapy, but the people who are not diagnosed with cancer are typically given bortezomib, which is an anti-plasma cell therapy. And that actually has been used in veterinary medicine. There are reports of it, but they're basically phase 1 safety trials, maybe some phase 2, looking at some cancer patients. Certainly not something I was familiar with or had experience, nor did my oncologist have experience with. Another therapy that would be used would be JAK inhibitors as well. And those are drugs like ibrutinib. And similarly, ibrutinib has been used in veterinary medicine oncology trials, just 1 or 2 safety studies essentially. And so there is some data there, but not something that we've used with any routine experience, even amongst oncologists. Our oncologists weren't even familiar with these drugs. So we decided to try cyclophosphamide because it would be more targeted for B cell and T cell rather than mycophenolate, which is going to be a little bit more T cell driven. The thought was, well, it's going to be cytotoxic and probably have a greater chance of side effects than these more specific therapies in people, but we have experience with Cytoxan, we don't have experience with those other drugs, and who knows how they would go. The dog is clinically feeling pretty good. You could argue, and some of the MDs did, why even bother with immunosuppressing this dog? Its kidney function has been stable. And yes, that is true, but we do not experience the clinical remission rates that they do with humans with membranoproliferative GN, where they might just not do anything for 6 months and more than 50% of patients are going to self-resolve and go into remission without immunosuppression. We don't have these rates of improvement that they do. And maybe it's because our patients are being treated later, maybe they're different diseases, maybe we haven't optimized our drug therapy. But I thought if we wait until the patient progresses, we probably could miss a window of opportunity to delay that. So we elected to move forward, and we did prednisolone and cyclophosphamide, oral cyclophosphamide therapy. And we did that for about a month, rechecked the dog. The dog was having some GI signs, which seemed to be related to the cyclophosphamide. It was doing better before we had added that, and then once we added the cyclophosphamide, it didn't seem to do that great. It was having some nausea. After about a month of sticking it out, though, we did see that the recheck UPC did not make significant improvements. It was 4.4 compared to, let's say about 2-ish or so right before the biopsy. And perhaps a month is not long enough. And I suspect that it probably isn't to give time, because I don't think cyclophosphamide at all is going to allow for these deposits to resolve. It's just going to help slow the deposition of new deposits. So it's probably not long enough, but we did take a break from that because the dog was having substantial GI signs. It did have a little bit worsened azotemia as well too. Part of that was probably just due to the GI losses, in addition to ramping up its ACE inhibitor therapy and whatnot. But currently the dog still has a creatinine of 2.6, a BUN of 94, which is a bit worse than where things were from where we started. It was 2.3 for its creatinine, but not significantly. And we're just basically writing out this pause in therapy and trying to determine where we go from here. From a diagnostic perspective, we did do an ultrasound. We didn't see any evidence of cancer. We didn't do a bone marrow. We had no obvious evidence of that. We did perform an SPEP and immunofixation. So there was no evidence of a monoclonal serum gammopathy present, and serum immunofixation was also normal and unremarkable. So aside from doing a bone marrow, which is probably a bit more invasive than what I think we were going to get from it, we did not find any evidence of a monoclonal gammopathy in this patient at all. So that's kind of where we're at this juncture. We're still managing the dog and now trying to decide, do we move to bortezomib, ibrutinib, medications like that, which would be cool. I mean, the names sound pretty awesome, so the drugs have got to work pretty well, right? But who knows what can of worms we might be opening at the same time.
Yeah, I think it gets frustrating from somebody like for me, who has been trained in multiple different species, but one of them being humans, is that this is a slam dunk diagnosis in humans. And we know once you see the microtubular appearance, blah, blah, and then you have to go figure out, why are they producing these microtubules? And usually you can find an underlying problem that would be creating the organized deposits. Not always, but we have drugs for it, right? So it doesn't necessarily mean that you got to figure out exactly what the exact composition of the deposits are. We just go ahead and suppress their plasma cells, get rid of their plasma cells, like just get rid of them totally. And so that, but to be honest, as much as I say this looks identical, and I don't know, JD, did you send the report to the listserv for or at least the EM images of the microtubular stuff?
Yeah, I sent our biopsy report to the ASN discussion, and nobody had specifically commented on differences between the pathologic findings. It was more so the nature of the underlying trigger for it.
Yeah, I agree. And so it just, but who knows? Like, it doesn't have to be that just because in humans, oftentimes it's a part of an immunoglobulin, a fragment of immunoglobulin or whatever. It doesn't mean it has to be that in veterinary medicine. It could be, I don't know, some other random liver protein. It could be anything. It doesn't necessarily have to be that. And so, and when I said we have only 3 or 4 cases of this, we do have probably a cohort, which I think I presented at ACVP years ago, of at least 15, and we probably had more since then, glomerular deposits that were too thick to be amyloid, but not microtubular and not as thick as this. So they would fall into that category, which I was talking, which is just called fibrillary GN. And so we have cases that fit into that category, but we haven't been able to show any of those have fragments of immunoglobulins. So just because in humans it's the immunoglobulin that's making the deposit doesn't mean it could be any kind of other protein that can form a fibril and get deposited in this. So then your question becomes, is there anything else we could do diagnostically? Well, if we had a lot more tissue, which I'm not saying you need to go get more tissue, but if the animal does eventually progress to the point where the quality of life and needs to be euthanized, or the owner elects euthanasia, like getting more kidney, we can do mass spec on it. And that's our next step to say what were these deposits composed of. And so that's a possibility. But that would obviously be in an end stage situation anyway. But I mean, that's all we're going to be able to do to figure out what things are making these proteins. I guess maybe we can find Cheyenne's kidneys, because I think you sent us a lot of tissue, Dr. Shropshire. Although, I mean, obviously this will all have to wait until Dr. Hokamp gets to Texas A&M and we figure out their mass spec situation. But that would be a possibility too, is trying to figure out if we can see through that methodology what the fibrils, or at least what the fibrils in Cheyenne are made of. It doesn't even mean it has to be the fibrils in this patient either. So it's an interesting finding. I don't know if any of the pathologists out there have other comments. I'm going to say no.
I put it in the chat, but I mean, you guys know I'm always in liver rounds,
Yeah.
you know. So I've definitely seen some of these weird fibrillar deposits, you know, that we've sent off for EM that is larger than amyloid. And actually one of the cases was a cat with hepatic and renal strange fibrillar deposits. But I think, you know, I was just curious if the corgi ever had elevated liver values, because it happens in people that they'll get elevated liver values. And then in the 2 dogs that we've seen, it's like cholestatic. I don't think necessarily perfectly damaging, and the pattern is usually random, you know, and you'll have random apoptosis. But then the other thing was, I guess, you know, again, kind of thinking about, again, parallels with the liver is, you know, I'm just curious, how do we know? Obviously, like you said, the problem with knowing how similar it is to humans, but also, you know, when we think about some sort of triggering event, you know, what if those fibrils are there and what's there is there, but not necessarily continuing to be laid down? And so it's almost like we talk about glomerular sclerosis, where for some reason it's sclerotic, but, you know, again, different to humans is not a lot of those dogs will respond to immunosuppression. So maybe that's something that occurred at some point, and you're more focused on, you know, just trying to protect the kidneys from ongoing magnitudes of proteinuria. So is there any way, other than rebiopsying the corgi, of course, to tell, because just based on the differences between Cheyenne and the corgi, you know, like Cheyenne has like lots of inflammatory infiltrates, you know, going into the arterial lumen, you know, extremely hypercellular glomerular, whereas the corgi didn't so much. So I wonder if it's something that happened and it's not necessarily an active process, but I don't know how you can tell.
Yeah, and I don't think that there is a really good way for us to say activity or recency of deposits, whether, and it could be any kind of deposit. It could be an organized substructure deposit like this, or it could be a deposit that was an immune complex deposit. The MDs like to talk about on membranous, if they have just like kind of humps on the surface and not much remodeling of the glomerular base membrane, they'll say that those are fresh or recent deposits. And I usually agree like with that concept of like, it takes a while for the base membrane to remodel. So it would make sense that if you just have the deposits and you don't have remodeling of the GBM, it probably did happen more recently than, you know, years ago. It probably was something that happened in the past few weeks. But in general, otherwise, we don't really have a great way. And we don't also have a good time course for when deposits should resolve. There is the ability for podocytes and mesangial cells to kind of eat and nibble at deposits to try to get rid of them. But whether or not, you know, how long that takes, how, if there's any other way that they can get absorbed or dissolved, we just don't really know, because we don't have a time course of the patient had it, was that as soon as they started with their deposition and then eventually progressed and we were able to rebiopsy them every 2 weeks. We just don't have that.
Yeah.
But yeah, I like your idea, and that might be why cellular wise, the two cases were different, and had Cheyenne resolved, and maybe had Cheyenne like not had the external stress of also being pregnant with 11 puppies, her
Yeah.
kidney might have been able to like hold on to a little bit and then of renal function, and then this would have happened later in the course. It's possible. It's definitely possible. So JD, do you know if there was any liver disease in Kobe?
The liver values are normal aside from a very minimal hypercholesterolemia of 337, and I don't know if that was fast or not. Otherwise, liver enzymes are normal on blood work. We don't have a bile acids or any other testing because we haven't had a need to interrogate the liver that much, but otherwise it's been normal.
And then the other thing that could be cool is more occasionally, you know, Russell Moore here occasionally does urine immunofixation for funsies, because his, you know, his PhD student is doing all sorts of stuff with immunofixation. So I could always ask him if the urine could be different, because he was just talking to me about how sometimes the serum immunofixation looks completely normal, but we have these two weirdo chronic ehrlichiosis cases, and their urine is completely different from an immunofixation standpoint than the serum. So I could ask him if he thinks it could be like a gee whiz and we could do for free on one of his research runs, if that sounds interesting at all. Or I could just even ask him and then email you.
I think that's a really good idea, because there can be discrepancies where even though it's not up in the serum, it's up in the urine. So Dr. Hokamp also agrees.
Yeah, I can.
If there's a possibility, then that would be interesting. And then, and like I said, we are obviously kind of going through lab cleaning mode, but when we find the rest of the samples that we have from Cheyenne, we could make sure that that is something that, because it would be nice to, if Kobe, I mean, you know, it's not like Kobe is going to be immortal. So, and I'm making sure I'm saying the name right. If this dog eventually does have to, or is euthanized for any reason at all, if you could get us some kidney from this patient, then we would at least have a couple to do in tandem for mass spec, just to see if we could get an idea what those fibrils are.
Sure. And I forget, I feel like we did submit this for SDS page, but I guess I can't recall off the top of my head. We might have.
The name doesn't sound familiar to me.
Let me look.
This one, is it Kobe or is this Cheyenne? I can't remember which one.
Posner.
Here, I can look it up real quick.
Okay. We normally do, but occasionally there are times when the day gets nutty and we forget to collect everything.
And then JD, did you want me to see if Moore can do the immunofixation?
Yeah, that would be amazing. I think we did the SPEP and serum immunofixation at CSU, so they already had those results. So yeah, if they could do urine, that would be amazing.
Okay, cool. I'll shoot him an email, or I think he's on service, so I can pop down and ask him.
Yeah, that'd be great.
That's great. Okay, well, so that was a gee whiz for everyone. That if you guys, for the first timers, it's usually not something so esoteric. And I don't see that there's an SDS page report in here. Okay, if I'm looking at that case right now.
I lied. I apologize, since it is in my list to do, and so I'll get on that. I'm admittedly behind on the biopsy ones because we've been getting so many urines. But that's actually on my list to get done this week. So
crack the case, Jess. Come on.
I know.
JD, Jessica, Kobe's submission form includes urine.
Yeah.
Yeah, I will. I already have the gel run on it. I need to get the report. So that's on me.
Okay.
Everybody's been busy. You don't need to feel bad. Okay. So
I just want to take a second too, just to say, like, this lesion, while at the end of this rounds, we might even be talking about two different lesions that we know almost nothing about. we wouldn't know about it, period, if we didn't have this. And I know I'm preaching to the choir, but there's no way that this biopsy, if it would have went to a regular diagnostic lab, we would have gotten anything close to the information that we got. So I think these cases are interesting and frustrating because we don't know the answers, but we're not going to get answers if we don't even know to ask questions. And just being able to get this information and open our eyes into things. I know I had heard of immunotactoid GN prior to this and could have told you that those words were words and that was probably it. And I know a whole lot more about it now afterwards. So I really appreciate just the expertise that we have and the ability to learn more collectively about kidney disease in our patients. So thanks to the whole team behind this. This is really amazing.
Thank you, JD. That was nice for you to say. Yeah, so we occasionally get to see real cool things. So, and I have to admit, like, just as an aside, I think I was texting Shannon McClelland, who is our person who sometimes helps us read EM as well. And she's actually a contractor now for Colorado State. So she does contract, but well, not a contractor. She works part-time for Colorado State. I think I was texting and I was like, hey, do you want to read some EMs, blah, blah. And I'm like, they're just some boring MPGN cases. And then I did, and then I texted a bad word and I was like, there's fibrils. I got really excited. It can be exciting to occasionally see something that is classic, but uncommon. So, okay, so I will log off. I'll stop sharing and stop recording, and we will reconvene in August, third Tuesdays at 1 p.m. So I think I need to send out new invites for everybody, but I will take care of that and get you guys some new Zoom invites for August. Okay, thanks. Bye.
Bye.
Thank you.
Thanks.